Kia ora koutou, nau mai ki tō mātou kōrero, me karakia tātou. Whakatakatia hau ki te uru, whakatakatia hau ki te tonga, kia mā kina kina ki uta, kia mā taratara ki tai. E he ake ana te ata akura, he tio, he huka, he hauhu, ti hei, mauri ora. Kia ora koutou, thank you so much for joining us for today's webinar. I'm going to pass over to my colleague, Joey, to welcome you here today. Kia ora.
Kia ora. Thank you so much, Moira. And yeah, welcome to everyone who is joining us today, whether you are coming in live, which we can see there are still people just popping in all the time. So welcome, take your time to arrive. And you might also be watching this as a recording. So either way, thank you for being here with us. This webinar, which I think some of you will be aware, is about the complexities of lab testing systems. It's particularly about how we're going to work around some of the barriers that come up for trans and non-binary people in this context. We're not suggesting that we have all the answers. We're not saying all of your questions will be taken care of in this 1 hour session, but we are really keen to be part of an ongoing conversation. And we have a great guest speaker here to contribute some expertise to this conversation as well. We know that you are all here because you want to support the self-determination and dignity of trans and non-binary people. That's a big push across all of our webinars, and today we're trying to talk about what that means in relation to lab tests. This is building on a previous webinar that some of you may have attended, and if you haven't, I'd really encourage you to go and watch the recording. That was about patient management software, and it really, these two topics really connect well together, so they kind of, we're seeing them as a combo. Our guest speaker today, I will let her introduce herself in a minute, but Melanie, it's great to have you here. Melanie is the Laboratory Quality Manager at Waitematā District, Te Whatu Ora. But first, from an organisational perspective, a little blurb about Te Ngākau Kahukura. We are a rainbow and trans-led organisation. We are doing systemic advocacy and community building work with and for trans, takatapui, intersex and rainbow communities and organisations. Yeah, and today's webinar is part of an ongoing conversation which has centered around topics like patient-centered care, informed consent, respecting privacy, and supporting self-determination. We're aiming this webinar particularly at people who are working in healthcare contexts around New Zealand, but we also know we have often quite a wide range of attendees to our different webinars, and whatever your role is, we welcome you into this space. So practical Zoom notes, Moira, before we do a little intros round.
Yeah, sure. Thanks, Joey. Webinar is being recorded, so please be mindful of that, and it'll be available afterwards on our website or our YouTube channel for you to watch or share with other colleagues, which we really encourage you to do as well. If you're familiar with Zoom, you might notice that your camera is not on. We can't see or hear you. This is a webinar, so it's only the ones of us on screen who are being recorded. So don't worry about kind of what you're wearing or if there's noises going on in the background, that's all good. But we can see things that you put in the chat, so feel free to introduce yourselves in there or add any comments or questions as we go through. We're going to have a presentation from Melanie and a bit of a chat amongst ourselves, and also save some time at the end for questions and comments from you, from the audience. But you don't have to wait until the end if you've got a question, or if you have a thought as we're going through or a reflection, feel free to pop it into the chat if you want everybody to see it and be able to interact with it. Or you can also use the Q&A function at the bottom of your screen if you'd like the option to be anonymous with your question. Really appreciate your comments and questions. It helps us know where you're up to with this topic and what your thoughts are, and guide the conversation in directions that are useful for you all. And yeah, appreciate people introducing themselves in the chat as well. It's lovely to know where people are from and what your sort of roles are in relation to trans health or healthcare more generally. The recording of this, as I said, will be up on our website soon after, and we'll send it out to people who've registered today, and the slides will be publicly available up there at some stage in the next couple of days too. So I think that's all my notes.
Yeah.
Maybe back to you, Joey.
Cool, thanks, Moira. A little round of intros before we do a presentation, and thanks to those who are introducing themselves in the chat. It's great to see people who are so directly relevant to this topic joining us today. And please, we really welcome your expertise. So comments and reflections as well as questions. We're just interested in this being a conversation. So we're not imagining that all of the information is going to come from us. We think probably a lot of our audience members have really important things to contribute, and we would love to hear anything that you want to share on this topic. So first, acknowledging that we have Jono in the chat doing excellent things, recording your questions, taking notes on what people are bringing to this webinar today. Jono, it's great to have you in the chat. Thanks for doing that for us. And Moira, will you introduce yourself and then pass to Melanie and then pass back to me, and then that'll be our round.
Keep on going that way. Yeah, sure. So kia ora koutou, ko Moira Clooney tuku ingoa. He uriti nei no Aotearoa, ko ngai te potoki mo te karaka te hapu. So he whakapapa connections to the Hokianga up north, as well as to the other side of the world, to Scotland, England, Ireland and Orkney. I'm not a clinician, I don't work in healthcare, but I've had a background in public health, particularly in the kind of mental health promotion, suicide prevention space. And I work around kind of improving healthcare for rainbow and trans people as part of Te Ngākau Kahukura, and through work with the Professional Association for Trans Health, Aotearoa, and as an associate investigator on the Counting Ourselves project. So from more of an advocacy, research, education kind of angle. So yeah, really interested to hear more from Melanie today and get into the discussion. So I'll pass over to you, Melanie, to introduce yourself. Kia ora.
Thank you, Moira. Kia ora, ko Melanie Adriaansen. I am the Laboratory Quality Manager at Waitematā Whatu Ora Laboratories. I'm a registered medical laboratory scientist and have been for the last 15 years, that's too long. Yeah, just really passionate about this topic, supporting our rainbow communities, but just equity in general and making sure that all of our patients have a good experience in healthcare. And labs is obviously the space that I can influence that in. So yeah, just here to try and make sure we can move that along as much as we can. Thank you.
Kia ora, Melanie. It's so great to have you here. And for those of you who haven't met me before, I'm Joey McDonald. I'm the education lead at Te Ngākau Kahukura. In terms of whakapapa, mostly on my mum's side, that's English, back to Croftons of Essex, and on my dad's side, the McDonalds of Scotland, hence the last name. And I, similar to Moira, have not worked as a clinician myself, but I've worked very closely with a lot of clinicians and a lot of people working in healthcare contexts more broadly. We've been doing this work as Te Ngākau Kahukura, particularly around trans and non-binary health and advocacy, and ways that we can improve the system and make it more responsive, which we know often means just connecting people who are working in the system more with each other, giving you a chance to talk to each other, not really necessarily us talking to you, but you getting a chance to talk to each other. So we appreciate you being here for that. I won't keep talking about various hats, but similar to Moira, I work with PATHA as well, the Professional Association for Transgender Health, Aotearoa, and with our various community organisations who are doing important work in this space. Okay, we are ready for a presentation. And again, these slides are going to be available in the next couple of days, so you don't have to be panicking if you can't write things down as they come up on screen. Whenever you're ready, Melanie, feel free. Looking good so far. This is always that moment where you're hoping the technology will.
Is it going to play?
Play nice.
There we
might
go.
get, yes. Okay, take it away.
Thank you so much. So I'm going to quickly do an introduction so that we're all on the same page and have an understanding of what the experience of being transgender and non-binary might be like. Many people choose to undergo hormone therapy, although not everyone does. It's called medical affirmation, and that helps align a person's physical body with their gender identity. Some people will go through social affirmation, for example, where they change their name or gender markers without actually going through medical affirmation. So speaking to the healthcare context, that means that, you know, in the labs, for example, somebody's gender marker and name may not match what their hormone levels reflect. There are two main types of two pathways for hormone therapy. The first one is testosterone therapy, which tends to lead to increased muscle mass and decreased fat mass or fat mass redistribution. And then estradiol and anti-androgen therapy, which is leading to a decreased muscle mass and increased fat mass. and fat redistribution. So what does this mean for laboratory testing? In the labs, there's 3 possible scenarios that we can look at in terms of how we would receive samples. And the first is that there's no indication to the labs of the patient's transgender or non-binary status. In this scenario, the sample would just be processed according to whichever gender marker is attached to the person's NHI. And that may not match where the patient is at. For example, somebody may have commenced hormone therapy, but the gender marker may not have been updated on the NHI yet. So yeah, there could be a mismatch in terms of that. The second scenario is that there's no sex or gender indicated, or another gender or other gender is selected, in which case we may put results out with no reference ranges or with default reference ranges, and that will vary depending on which lab you're using and how the settings are and which tests you're selecting. The downfall of this is that it relies heavily on clinical interpretation. And then the third scenario is that there is a transgender or non-binary status indicated, so the labs knows about it, and this is an ideal scenario for us because we'll be able to put things out with the correct gender, but often it still results in delays of processing those samples. So in the first scenario where there's no indication to the labs, this is probably the most complex scenario. There's no easy way within a healthcare setting to communicate to a team of clinicians easily and quickly that the person is transgender or non-binary. We have quite significant limitations in our current IT setup and our electronic medical records, which make updating the patient information challenging. Often there is no easy way to put in new genders or other gender options or another gender options. And there's no way to push that out to the different IT systems that each discipline is using. In a worst case scenario, I think for phlebotomy, our phlebotomy team are the ones collecting patient blood. And so they're the patient facing group. They can address transgender or non-binary clients with dead names, which is the names they're no longer using, because those names may still be attached to the person's NHI. So yeah, as I said, incorrect names, pronouns, and sex markers, which can cause distress and dysphoria for the person who's having their blood collected. This also causes a lack of visibility. So we really don't have any good data from hospital systems in terms of how many transgender and non-binary people are using our healthcare services and what the outcomes and experiences are like for that group. So without having an IT system that can capture transgender or non-binary identities, there's no way of us measuring the group, and then also it makes it difficult to advocate for need for improved services. So an ideal solution would be to have a significant IT upgrade where we can accommodate this group more easily. There's a good reason why we haven't just gone ahead and done the IT upgrade. This is quite a high-level overview of some of the current IT systems used within Te Whatu Ora healthcare services. There's over 20,000 different IT systems currently in use, and even trying to get them to talk to each other is a big challenge. The labs sit here in this diagram, and even within the labs, you can see that there's 6 different software programs being used. But I know some disciplines within the labs, some of our departments will already just use 6 systems on their own. So in order to have appropriate information around gender and sex, we would need to upgrade each one of these IT systems. And some of them are quite outdated now and probably would get replaced anyway. So I think that's the direction Te Whatu Ora will probably head in, but they are doing planning around how we can better accommodate sex and gender identities. In the labs, pretty much all of our information is controlled by the NHI system. Speaking from the hospital-based care, it's different in the community setting. So we have an NHI system which has a gender field only, and this pushes the information through to IPIMS, which is our patient management system. And then that pushes it through to pharmacy, labs, and radiology and our other services. In 2020, IPIMS actually did build in a second gender field, but that information doesn't feed back to the NHI, and it also doesn't feed very well into the labs, pharmacy, and radiology IT systems. So There was some initial goals that we would develop IPIMS integration so that it could correctly send gender and NHI send gender information back to the NHI. And that way there'd be bi-directional communication. We would also want to develop IPIMS so that it could properly push down sex and gender information to other systems such as ACLEAR and Delphic, and the LIS, which is the Laboratory Information System. And that would allow all systems to be communicating to each other. So just a quick note on the NZNHI system. With the current forecasting, we're due to run out of NHIs in 2025. We currently create 12,000 new NHIs per month, so we go through them quite quickly. And so they're developing a new NHI format, which is due to go live on the 1st of October 2025. And this will be an alpha, 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 numerical alpha with a check digit in place. So it's a longer NHI number. When I had originally looked at this, the data collected into that NHI system was going to be a sex assigned at birth. With these categories available, I've put a big question mark next to that because I can't find that reflected in the current information that's been released. However, there is a mandatory gender field that has male, female, another gender, and unspecified or unknown available. And that's mandatory for people to complete. And if another gender is selected, then there'll be a free text box available for people to choose the gender identity they would like. So I had originally hypothesized that labs would use this format. It can be very helpful for us to know both the sex assigned at birth and the gender category. Although probably having further information, such as whether the person is on hormone therapy or whether they've gone through gender reassignment surgery, would also be helpful for us to have. So looking at flagging abnormal test results, we've got an example here of a patient with a low hemoglobin value. The female reference range is 115 to 155 grams per litre. So this person would be just below the reference range with 113 grams per litre in terms of the female reference range. But in terms of the male reference range, they're quite anemic. So having that person's history and background, knowing whether that would require a referral onto a hematologist for further investigation, that's where having background information is really helpful. So our laboratory information system is designed to attach patient demographics such as the sex and age to each sample and then apply the appropriate reference ranges and then flag abnormal test results. However, if the test results are not truly abnormal or if the sex and gender are mismatched, those reference ranges can be inappropriate. And that can be confusing or meaningless. And in worst case scenarios, could lead to some pretty bad health outcomes for patients if emergency treatment was required. So I've got an example of blood transfusion here. We have really strict criteria for labeling. So I think if there's a mismatch between the sex, between the sample and the NHI system, that could lead to some heavy questioning and possible sample rejection. The reason why we have such strict criteria is to prevent transfusion reactions from happening. We know that being really strict around how labeling happens on our blood transfusion samples does reduce the risk of error. In the current blood banking system, so we use the New Zealand Blood Service system, patients can have an alias recorded. So that's good to know. It's just a matter of how do we know when a patient needs an alias. So we need to get that information still sent through to us. Currently, there's protocol out to issue Cal negative red cells to people of childbearing age. So that's generally people who could get pregnant. We want to prevent anti-Cal from developing, which could have consequences for a fetus. So in the current setup, we could potentially miss trans men from receiving Cal negative red blood cells. So that's an example of where if a trans male received Cal positive red blood cells and then went on to get pregnant later, that could have some pretty serious consequences for the fetus. So in the scenario 2, If there's no sex or gender indicated, so we select other within the computer system. I know we don't like the term other, it's othering. Unfortunately, with our current IT restraints, we have male, female, or other as the option. There are 44 tests that we've identified within laboratories that have specific male or female interpretations. And this is kind of a simplified list, and you can see in the default reference range columns whether the default reference range becomes male or female, or whether no range is applied. If another gender is selected, a comment such as this could go out with the patient's notes. The patient's gender was not specified. Reference ranges may be gender specific, and this should be taken into consideration when interpreting the result. If the patient is on treatment for gender reassignment, this may also affect interpretation of some tests. And so a third example, this is where an example of where if we do know that the patient is transgender or non-binary. So for example, a trans male in their 20s presents to ED. The lab sample is marked as male, yet a high vaginal swab is requested. Then the person registering the sample needs to deregister the male sex marker, register the female sex marker, request the test on the patient, and then re-register the patient with the male marker. It relies on our lab staff having sufficient IT knowledge to know that these are the steps that they need to take. So it often still results in confusion within the lab and then delays with processing the sample. So there is a transgender healthcare research group in Australia that have recommended that as soon as somebody begins hormone therapy, the new gender reference ranges should be used, or sorry, the affirmed gender reference ranges should be used. But the question is, how does the lab know or if somebody's on hormone therapy or when that hormone therapy has started? We don't get that level of communication given to us in any way. So we really do rely on information provided on lab forms from clinicians to know that we should be attaching the new reference ranges. And then in terms of reference ranges, we have different options. So either no reference ranges could go out, a wide set of reference ranges could go out. So for example, with the hemoglobin, you've got the lower cutoff from the female reference range to the upper cutoff from the male reference range. Potentially you could have both male and female reference ranges go out, or mixed sets of reference ranges depending on which lab tests you're requesting. Currently with the IT setup, most of these options are very difficult to achieve, and just a default male set of reference ranges or female reference ranges will go out. And then lastly, onto what's happening in the lab space. So all labs should be aiming to remove sex-specific testing restrictions. And by this, I mean pregnancy tests, we should be able to request them on any gender. The prostate-specific antigen test, the PSA test, should be able to be requested on any gender. That can also introduce an element of risk. For example, in the labs, we do see a significant number of elderly males still having pregnancy tests requested on them. We know clinicians get a bit tick happy and go down and just start ticking boxes. So I would encourage labs to have standard operating procedures available on how to process samples from transgender individuals. That's things such as deregistering the sex marker, and then registering their tests and then re-registering the correct sex marker so that those lab results go out with the gender affirmed sex marker. In the community testing space, lab tests, which is now Awanui, are working on making it possible for the patient to select the sex marker that they will have printed on their final reports. And lastly, the updated sex marker still relies on the doctor providing labs with sex and gender information. So I think for pretty much all labs, we rely on that information being pushed through to us from clinicians. Yeah, so that's everything. I would be interested in inviting discussion now, and I would love to hear feedback on what people in the chat would like to see from labs going forward. And any specific scenarios or comments is great. Thank you.
Thank you so much, Melanie. It's really helpful. I mean, for me, as someone who is completely outside of the complexities of lab testing, and obviously I don't work in primary care or secondary services either, but but because I work in community spaces with other trans people, I'm likely to hear what the experiences have been like for people trying to, get their blood work done, or various points at which you can have your wrong name or your gender not affirmed in some way. And I think that what you're spelling out is so helpful to show that real background to it, the complexity of it, and the ways in which you might be working really, really hard to understand what's going on and respect the self-determination of that person with the information that you have, which may well be very incomplete. And then you're trying to, deregister, re-register, do a workaround, take them off this list, put them on this list. And not surprisingly, that takes time. Not surprisingly, that means, you are going to experience delays that then get passed on to the clinician and the patient. And certainly from a patient's perspective, I don't think we ever have any idea why that is happening. So it's just helpful to me. It's like pulling back some kind of mystery to it, and making it seem less, it's less, that's less like a personal offense. It's less like, oh, I'm so hurt by this. If I can understand the system and see how it might fall down, even despite people's intentions to make it work.
I want to comment on that as well, and say that we do have a number of scenarios where there are genuine mistakes or errors made, which are not related to the transgender and non-binary. So as the quality manager, every week I'm dealing with a scenario where a patient's identity has been potentially not marked on the form correctly. So if we get somebody's information through and there's a mismatch between like the name and the sex and the gender identity, it's like, is that an error that a clinician's made labeling the sample versus is that person transgender or non-binary? And that's one of the kind of problems we have to try and troubleshoot.
It occurs to me like so much of this is about computers not being set up to account for the existence of trans and non-binary people and intersex people, right? That there's not really a way that you can kind of calculate which box people fit into. And one of your examples of the solutions was putting a note in to the clinician about, this is what I think is happening. This person is transgender. And so this is the reference range you need to be looking at. And it feels like a lot of the solutions around this, some of them might be IT fixes, but a lot of them are sort of human interactions, going back to the name of this session. Like so much of it is about kind of communication and being able to ask questions and provide information. That's really
so I'd be interested to know as well from you then whether, if we start putting those types of notes into patient clinical records, whether that's unnecessarily outing a person, because, you've got a whole group of clinicians accessing those medical records. And on the one hand, we want to communicate that important medical history. But then on the other hand, the next time that patient presents to a hospital, it could be for something not related to their trans care. And then yet the entire team is going to know that information. So we've had that issue asked as well, is it appropriate to put somebody's, previous sex or sex assigned at birth in with their records?
That's I feel like the crux of one of the difficulties with this situation, where if you want to respect somebody's self-determination, then on the one hand, that means engaging with them entirely as they know themselves to be and using the correct name and pronouns and understanding who they are, and possibly respecting the need to be stealth, respecting the need to not give people information about your history. But there are some contexts in your accessing health services where that history is really relevant. So you really might want to be sharing that information, but how can that information be shared in a way that emphasizes that it is historical background information and not the person's current identity, and to encourage anyone looking at that information to know that respecting the privacy of that person means only ever referring to them based on the most up-to-date information about their gender and their name, and relatedly their pronouns. And that is a really hard thing to get right. I don't think there's a simple solution for that, but I do think that the more we talk about the kind of challenges that are happening, the more chance we have that people who are looking at records as clinicians or as just people working in healthcare contexts broadly, that they'll understand what the painful parts might be for trans and non-binary people and find ways to work around them. You know, because what we know is that if people don't feel super comfortable about trans stuff and they're not really sure how to refer to someone, if you know both the sex they were assigned at birth and their gender, and people get a bit thrown sometimes and think, oh, I don't know if this is about your health, should I be talking about your sex or should I be talking about your gender? And then how does that even relate to who you are? And if we can get clearer that gender is always the way that people need to be referred to, or anyway, it's complicated because people might use the words gender and sex interchangeably, right? But it's a thing to navigate and it's not a simple fix. I don't know the balance, but there's got to be some kind of balance of giving enough information to the people who need it to manage the health risks, to manage and if we understood why that information was being shared, we'd be more likely to consent to it and understand why that was happening. I don't think very many people get that explained to them, that, hey, in order to do this blood test, the reference ranges are male and female, and I need to put this down for this reason. Is that okay with you? If clinicians did that with their patients when the blood work was being sought, I think that would really help. And that's that kind of transparency and collaboration that we talked about in the previous webinar with Cassie being so fundamental. It's not just about fixing the system and how it works. The IT systems need improving for sure, but there are things that we can do that are about, often the clinician, but sometimes also someone working in labs, working in phlebotomy. Is that how you say that word? With your front, patient facing, there are things you can do to try and explain why is this coming up as a difficulty, and explain what you're doing to work around it without making that person's problem. You're not saying they're wrong. You're not saying they are bad and confusing and their gender is incorrect. You're just saying the system is a bit broken in this way, or it doesn't quite cater to everyone's needs.
Yeah.
Yes. We've had some great questions come through.
I haven't been reading the chat as I've been talking, so you'll have to fire them at me.
I will. I will. And thanks to, I'm getting some backup here about knowing how the purpose of the test request is a core component of how to do this well, try to understand, in terms of what the reference intervals are and why the requester is doing the test. And it's a lot of potential layers for people to be navigating, but I do think people can do that.
Yeah, I mean, we had talked about self-determination a bit earlier, but I think, I really want to encourage people to be questioning their clinicians in terms of why do I need this test and what is this test for? The more questions you ask, the better. But I'm also at the same time really aware that when people come into our healthcare system, sometimes within the space of half an hour, you can come into contact with 5 or 10 different clinicians who are doing different roles, and having to explain your story every single time or ask those questions every single time is labor intensive for the patient. And I don't think it's fair to put that responsibility back onto them either. But either way, if you are in a space where you want to ask questions and you're in a healthcare setting, please do always ask us questions. That's your right to know what is happening with your health.
Moira.
Yeah, I was thinking too, part of the complicating factor around this is if you're dealing with lots of different clinicians, that there is just a really wide range of knowledge and understanding about trans health and about what the implications might be of being on hormone therapy or of pursuing other types of medical support around transition and affirmation. If one of the potential answers is to provide both reference ranges back to a clinician and to have the clinician interpret, some people will feel really comfortable with it and will be able to do that, and others might not be as confident.
Yeah, and it's also one of those things within, if you're providing both sets of reference ranges, which do we decide is the ones we're flagging as normal versus abnormal? I mean, I know already within our healthcare setting, clinicians are reading through so many lab test results, and there is a problem with them only reading those that are flagged, as they only care about the ones that are extremely abnormal. So yeah, how can we train the eye to be looking for what is relevant to that individual, as opposed to just how we do our population-based health, you know. Mm.
One question that came in that I think you have thought about, Melanie, and maybe not having all the answers anyway, but was about the new HPV program, and whether any changes are likely to be brought about because of that. Any thoughts you have to share on that topic? Someone raised that even ahead of the webinar.
Yeah, so we've moved away. Well, we're going to move away from the cervical smear to the new HPV, which is like a swab. I imagine that moving forward, that's going to be a lot more comfortable for many people, because it is something you can self-administer, so you can choose to just do it yourself.
That's so good.
Yeah, it's not explicit on the website whether that means people can do it at home, but I think clinics will be making it so that people have private spaces where they can do their own collection. Unfortunately, I don't think it's going to change much again in terms of the IT setup. So I know there's been an issue with whether people with cervixes are registered to the smear program or the HPV program. So I imagine that the algorithm in the background is going to stay the same. So people who have an F gender marker will be registered to get updates or reminders. And if you are registered as M for male and you want to be on that list, you would probably have to self-select to be on that list for reminders. Yeah.
Thanks. Yeah,
It's
yeah.
another kind of classic example of computers not really being set up to account for trans and intersex people, right? Like, in an ideal world, I think in the last webinar that we had with Cassie talking about computer systems, one of the ideas that was brought up was around an organ inventory. So rather than just having 2 boxes, M or F, and you kind of assume what sort of bodies people have based on those, that it's more like there's ways of recording what types of body parts people have or don't have. And so it might be that in an ideal world, you'd have a system where if somebody was assigned like an F at birth, it might tick the cervix box, but you could untick that at any point or switch that around depending on people's individual circumstances. But tricky for now.
And then the smear program needs to be linked into that. So when you so that's all the systems need to talk to each other, I think, is really the thing. Once you've updated one system, that should feed into every other program that's happening. I imagine that's where Te Whatu Ora is going. They do have quite a significant investment into looking at our IT infrastructure. So I'm quietly hopeful that we will see change in that space.
Which was part of what we were hoping with this webinar. It's a chance for people to think about what they might want to say if there were opportunities to be consulted or give feedback or form a working group or think about ways that you could be part of the push to when Te Whatu Ora is making new IT systems. If you have a chance to weigh in on the things that you think are relevant to consider that could be improved, this is an area. I mean, obviously, it's not just for trans and non-binary people's sake that we want all these systems to talk to each other more effectively. That's going to be beneficial to absolutely everyone. But there are ways in which, some of these barriers come up for us particularly clearly. And so we appreciate,
really recognises a gap that sex and gender information and ethnicity data are both the two kind of areas where we're not collecting information well. So those have kind of, they are priority areas. I know we are closely watching what they call the HL7 Gender Harmony Project, which is happening in the US. I imagine that a lot of our IT systems, we don't develop them in New Zealand, we purchase them from overseas. So probably whatever happens with that Gender Harmony Project will influence what we are capable of doing locally. So
Yeah. A great question that we may not have the answer to, but that I think we will probably look into afterwards is asking who's the best person to talk to at Te Whatu Ora about IT systems at that strategic level. If anyone has any contacts they want to pop in the chat, feel free to do that.
I would love to give you contacts, but I feel like I may be unpopular if I start putting people's email addresses out.
You could get in touch with Melanie after this webinar and see how that goes.
Yeah, I'm quite happy to, listen to people's feedback. Like I said, it's even having given this presentation, I can say that it's not something which we're not paying attention to, and there has been over time interaction or consultation with the transgender community over what they would like to see. So we've based a lot of our thoughts around what happened with Stats NZ and their recommendations for data collection. And Stats NZ did do consultation. But aside from that, if I'm always open to receiving feedback. If there's something specific you want to see, or you have really strong thoughts about something, absolutely get in contact. I am linked in with our IT team. I'm quite happy to pass that feedback on, or where appropriate, put people in contact with each other. So
I've heard you mention the words working group.
Yeah,
I love to hear these words, a potential way forward.
So yeah, there is an IT working group, but I would consider setting up a labs working group where we would just clearly list what our known issues are at present, so that at least we're all on the same page. Different labs are kind of coming up with their own workaround solutions as to how to manage various things. So like Lab Plus have done quite a lot of work, because they do quite a lot of specialist testing at Lab Plus, which is Auckland Hospital. So they've kind of come up with some of their own ways of putting out reference ranges. I know Palmerston North at the moment is currently engaged with one of our lab IT vendors. The vendor is very keen to come up with a way of doing lab testing in a gender inclusive manner. And my concern around that work is that even if the lab does it, the lab will end up siloed from other healthcare systems. Like I said, the real thing is to try and get all the systems talking to each other. I have a lot of faith in our local IT system, IT team at Waitematā, and I've raised this issue with them a number of times. And every time we look at it, the problem comes down to the fact that, well, even if we put this into our lab system, it's not going to talk to any other system. So that information won't go anywhere, Yeah.
A few other questions that we could try and touch on in our next 5 minutes, maybe. So what channels can we use to communicate the health risks to patients? I wasn't entirely sure what is meant by channels, but what channels can we, as I understood it, and if the person who asked this question wants to weigh in on the chat, please feel free to elaborate, but I understood
Do we
it to
assume
mean,
that this has come from a clinician asking this? So the healthcare provider is asking, how can we communicate with the patient?
Oh, I don't know if this person is a clinician. I didn't.
I mean, I guess, okay, so, to summarize, I think we currently don't have a great number of channels even set up between the labs and other services, between the labs and like the transgender non-binary community, between healthcare providers and the non-binary transgender community. I was, in the back of my mind, like I said, if I put a working group together, I quite like the idea of putting out like a position statement that's just publicly available, where it says like, we've had this working group and this is what we've identified as our problems. Unfortunately, we can't do anything about them at present, but we recognize that there's a need for it and you're not invisible,
Yeah, I think that does help.
Yeah. So yeah, like I said, I think there isn't great channels available for that communication at present. I've just relied on personal connections, really. So
yeah. And I can see someone else is suggesting possibly an information pamphlet for trans and non-binary people at collection centres might be a good idea. It's true that anything that helps explain, why these reference ranges are being used or are an issue and how that relates to some of it seems like, based on your slides, Melanie, it's a fairly complex thing to try and explain all of the ins and outs, but there are certainly some key pieces there that we could be trying to communicate clearly, even though, we want to do that with the goal that people can navigate the health system more effectively with their dignity. We don't want to be putting that person in the position where they have to have all the answers and know all the workarounds themselves. So we also need to be sharing that exact same pamphlet with anyone who's part of that healthcare system that might be facing that trans person, because I think that's one of the gaps that can happen too. There can be an upskilling on one side but not the other side, or
Yeah, and I think that idea of having a pamphlet or something is really lovely too, in terms of being able to communicate sort of the values type statements, like being able to express that that we care about sort of self-determination and trans people are valid. I don't know exactly what you would be saying, but I think there's a big difference between sort of explaining that you care about and respect trans people, and you might see the wrong gender marker for these particular reasons on your results, versus just not having that and seeing it without that context.
I've definitely, gone to get my blood work done and been confused about why on the script it says TG, and when I'm handing it over, I'm like, oh, I'm very out as a trans person, this is my job. But I still had a moment of being like, how's this person going to respond, who is probably the phlebotomist, when I pass this piece of paper over? And I didn't know how necessary or helpful that information was to that person. And if my doctor had said, that's why I'm putting this down, because it will help them do the right reference ranges and interpret the data, and the more information we can share, the better. It's not an unnecessary outing, this is part of your medical history and it's relevant. That would have really helped me feel calmer. And a lot of people are not as out and all over the place as I am. So I can imagine.
It's amazing what communication can do for us, right?
Right. Yeah.
Okay, well, I'm definitely keen on taking up the idea of putting together an information pamphlet. So thank you to whoever suggested that. And
awesome.
Maybe Joey and Moira and Johnny, we can have a chat later about what that might look like.
Yeah, great. And if anyone who's here in our webinar at the moment wants to feed into that or have further conversation with any of us, you can definitely get in touch with us about that at Te Ngākau Kahukura or to Melanie. But we'll all be connecting afterwards to try and pull together what we think some of the next steps might be, which again, we're not imagining will solve all of the problems, but do bits and pieces that we can. What about a question came through that was, are we saying the upgrade on the NHI in 2025 will be a solution? I feel like you were presenting that as a potential solution, a hopeful solution, Melanie. What can we do to manage the risk in the meantime? I mean, I feel that your presentation did answer some of that, and that those slides will be available. But if you have anything off the top of your head to say about managing that risk in the meantime.
I guess, firstly, answering the question on the NHI, I'm quietly hopeful that upgrade will see positive downstream impacts for all the systems. Although, again, how rapidly that will happen. Like I said, they've kind of currently identified there's 20,000 different, IT systems in use. To try and push that change out to every single system is going to be a huge amount of work. So, but I think once that's present, at least it's kind of the first, it's been the major barrier or hurdle to creating any change. So, yeah. And then secondly, to managing any risk in the meantime.
I mean, it's maybe too big a question, right?
Again, it's because, really it's just going to come down to communication is the only way that I can see the workaround. We rely on the information that we get from clinicians. Like I said, it's really hard for us to figure out, is this a mislabeled sample that you labeled in a rush and you've got the name and gender mixed up or put the wrong sticker on, versus this is somebody who, is transgender or non-binary, or, not even transgender or non-binary. We get people from different cultural backgrounds where sometimes the names don't match with the sex marker or whatever. So, and us trying to phone clinicians back and ask them whether what's correct or the correct version, it takes a lot of time. So it does help us to have that information on the form.
That's good. I think communication is a good answer.
I mean, at the moment, that's pretty much all. Like, I'd like to say that we could do fancy things with the reference ranges at the other end, but our IT is not there yet. So,
And it's the NHI changes you were signalling are only going to be part of the solution anyway, right? Because if you know what sex someone was assigned at birth and you know their gender, who they know themselves to be now, that combination of things doesn't tell you what kind of body they have or whether they've been on hormones or anything, or how that might have changed the results. So you can't kind of calculate Has to partly come down to communication.
Yeah, I mean, unless we start collecting other bits of information as well, like whether they, would build in an IT solution where, as well as the organ inventory, they'd have hormone therapy tick, like longer than 6 months tick, and then, I don't know, gender reassignment surgery tick, and then we'd be like, okay, this combination of outcomes makes sense given this medical history that we have, rather than us having to go back through and read somebody's clinical results or see, look at their pharmacy records and see what hormones they were prescribed, because we don't need that huge level of detail. We just need to know if somebody is on hormone therapy or not.
Yeah, so a tick box could work well. I'm pretty sure I've seen organ inventory type forms from other places that have that kind of tick box of, are you currently on hormone therapy? And it's great. It's so helpful when the information that's being shared is not oversharing too much detail. Usually as a patient, we can really understand when information might be required, if someone can tell us why it's required, but we would love not to be giving more and more and more detail. It's nice if it's just the bare minimum, what is required, what is needed, what will help us all manage the health risks. I think that's a great way to try and do it, knowing that no way is perfect. Okay, we're in our wrap-up stage. We've gotten through most of the questions that came through. I quickly wanted to respond to someone saying that they are wondering if they should change people's names. So they had a recent complaint about a dead name being in someone's previous records, and the question is, should we change all the historical records even when the dead name was, the only name that was known for that person historically? I don't know enough about how the record keeping side of things works to know how realistic that is to be able to change that name in every single place that it might pop up. But I do think a lot of people would appreciate it if it was possible to remove that dead name from the systems and put the correct name instead. That generally is really going to help, because otherwise, as we know, since the systems don't talk to each other, if you receive communication from another part of the hospital or another screening program, or it might well be using your dead name, which can genuinely be very distressing for people. So as much as possible, yes, we would like you to erase the dead name, not just from this point onwards, but retrospectively, knowing that might not always be actually possible.
And I think, having that information available across the range of health professionals you work with, like attitudes around trans and non-binary people kind of differ in the healthcare system as they do across society. And so there's always that risk that someone has that information and perceives it to be someone's like real name or uses it.
I think, clinical records is not my area of specialty, but I guess from the clinical records I deal with, I think it would be a huge job to go back and retrospectively correct people's or update people's information. And also, I guess, bearing in mind that it's not just the transgender and non-binary community that change their names. People actually change their names all the time. So then it's like, well, how do we know that it is considered a dead name and we need to go back and change it? And it would be the same for the use of pronouns, like, I met with patient such and such today, she is lovely. Like, do we go back then and change that all to he? And I'm also not sure around the legality of it. Some documents may be like frozen because it's considered a legal record of that interaction with that person. But again, it's not my area of specialty, and I take on board what you say, and if there's an opportunity for me to feed that back to the wider healthcare services, I definitely will.
Yeah, I think we mostly want to acknowledge that it's a very real stress for people and that it might not be possible to go back and change it in every aspect of the system. But that is going to mean that people will make complaints, which is helpful. People making a complaint about that and saying that was unpleasant and hard is a useful and valid thing, which I think this person was probably saying, when we get a complaint, we want to take it seriously and respond to that. We take it as a sign people care about trying to make the system better. That's helpful.
Definitely complain. I feel
please.
like hopefully none of my seniors are listening to this webinar, because they may not be happy with me saying that because of the additional work that it creates for us. But truly, the only way we can improve our healthcare service is if we are getting feedback from people, and having that feedback in writing is really, really helpful. I always appreciate it greatly when people have gone out of their way to take the time and write feedback, especially when it's something that has, heavy emotions attached to it for you. Like I understand it's difficult. So, but yeah, I do take patient complaints seriously, and I always try and act on them. So, yeah.
I appreciate that. And, you know, we're in our last 5 minutes. So mostly I'm just asking us to wrap up. And Jono has put in the chat a link to the page on our website that has more information about this webinar. Is going to have the recording of the webinar. That's where the slides are going to be in the next couple of days. You're also welcome to sign up for our newsletter or it's like our email list so that you hear about future webinars. That would be great. And we have a suggestion box for our suggest a webinar form on our website too, because that's how webinars like this happen. We find out that there is a need and we want to try and meet that need. So thanks so much, Melanie, for being part of this conversation, and thanks to everyone who has contributed really valuable comments and questions in the chat. This has been really a helpful, interactive conversation, which is what we were hoping for and what we continue to hope we can offer space for. Do you have any final thoughts, Moira, before I hand it over to you to close? You don't have to, or Melanie, if you have a particular final thought to share, anything you're hoping people will take away from this in particular?
I know, I think we've covered most of the core messages, I guess. Like mostly for me, it was I wanted to acknowledge that transgender and non-binary people exist. They are using our services, and we're not really accommodating them well, and it's not for lack of trying sometimes. So yeah. So
true. Thank you. Moira?
Thank you. And I think you did such a good job of showing some of that complexity of like, yeah, why it can be tricky to do things the way that we'd want them to be done. I think my only other thought was just, it seemed like there was a bit of interest in the chat around people continuing to stay in touch and potentially be part of a working group. So please do keep in touch, and we can pass your contacts on to Melanie.
Will I get access to the chat? How will I get in touch with people? Oh, you've told them to email you through the website?
Yeah, people can do that, and we can send you a copy of the chat as well after this.
Okay,
that's
great.
Helpful. I'll just share a couple of slides to say, Joey mentioned this earlier as well, and I think I referred to it, that this session has been sort of the second one in a series. We had a session with Cassie with Aotearoa a little while ago about patient management software and some of the challenges there to do with respecting self-determination of trans and non-binary people as well. So go back and watch that one if you'd like to. And we have a whole series of webinars on different topics to do with trans health, but also to do with kind of rainbow, trans, intersex health and well-being more generally, a whole sort of range of topics. So do feel free to check those out, join our mailing list, as Joey said. Go and fill in our suggestion box if you have a suggestion around another topic that you'd like us to cover, or someone who you think we should be talking to. And yeah, otherwise, just thanks again, Melanie. Thanks again, Joey. Thanks everybody who's been here for the great discussion and questions and engagement, and really appreciate your time with us today. I know how busy everybody working in the health system is, and particularly through winter. It's been a really hard time for people, so appreciate you taking the time to be with us today. And I'll just close us with a karakia, me karakia tātou. Unuhia, unuhia, unuhia ki te uru tapunui kia wātia, kia mama, te ngākau, te tinana, te wairua I te ara takatu. Koiara I rongo whakaere ake ki runga kia tina, huie, taiki. Kia ora everyone. Thanks for being here.